all of us up here on this panel have at one point or another been in a position where we're new to this, where we know absolutely nothing. And so, what we sort of take for granted in the things that we do in our practice and in our daily lives, which is, contracting with labs, it just sounds so simple. We're contracted with a lab for buying wholesale. We have prices on imaging. We have everything for wholesale, and we have our contracts. We take all that for granted. So what I wanted to do is bring up a panel of folks that are doing this, and just to share a little bit about their personal stories as to how they got here, and how to do the absolute essentials. But really, most of this I would really like to be Q&A. I mean, there is no question that's too dumb. There's no question that's too simple. No question that's too complex, and if we can address it here, we will. But we really want you to leave this conference feeling like you know exactly what you need to do to go home and start your own practice. So that is the entire point of this thing. So get your questions ready. And I'm just going to introduce our speakers here and let them come up one at a time as we go down the row here. This is my partner in Epiphany Health, Dr. Bill Crouch here in Florida. You saw Chad Savage the other day.
Hey, I'm finally amongst sharply dressed people. It feels so comfortable. Thank you.
Amy Walsh and Mike Champy. So I'm going to go ahead and turn the microphone over. Thank you.
Thanks, Lee. Good morning. Great conference. I've been doing this for a few years, but I've learned so much this weekend, and I appreciate the opportunity to be among peers. I think sometimes when you have been doing this, you really feel isolated, like you're on an island. And I was telling Lee earlier, it's kind of nice, for the meerkat to poke out of his hole and see there's some other meerkats. And so it's been a really good experience for me. We have a hybrid direct primary care model. And for those of you that already have an active full practice, it can be a very difficult transition into direct primary care only. And so the only advantage, I think, because you still have just as much overhead and all those things, is it just lowers your risk. There's a lot of risk, and there's a lot of successful people here this weekend that have kind of shared with us their success stories. But this is hard, and the marketing and all the things you have to learn, there's a pretty steep learning curve. So when you have a hybrid model, you're still able to build some insurances or take Medicare, which is what we do, while you grow the direct care component. The goal, I think, for everyone is to have a full direct care practice, and then you can flip a switch. But, when you have other personal financial issues, which are important because we don't operate in a vacuum, so you have to look at the big picture. And so for us, the hybrid model made the most sense, lowering the risk, multiple streams of income coming into the practice. And I think what we need to continue to strive to do is bring great value to the patient. And you can do that by not only giving them access to you, but using your existing referral patterns, going back to your colleagues, your specialists, your imaging centers, the mom and pop pharmacies at home, and try to tell them, I'm going to be sending people your way. Some of them may have insurance, some of them may not. Some of them may have high deductibles. And so the thing that's been helpful for us and hopefully our patients is to negotiate a very transparent price for everything that we do. I think that's what we value the most in direct care, is the transparency that it affords the patient. We have such a complex medical system, and to help them navigate that more efficiently and to be able to look them in the eye and tell them you need an MRI and here's what it's going to cost. They can plan for that event. So anytime you have an opportunity to speak to your colleagues that you're currently using, just say, hey guys, we're going to be sending people your way for colonoscopies, but for the cash patient, what can I tell them they can expect to pay? And to get a discount, if there is one, they should expect to pay in full at the time of service. And that usually is a win-win. Because you don't want them to roll their eyes when your patient shows up on their doorstep. You want it to be mutually beneficial. It's not charity. So it really has to be a win for all. And I'll be available for questions. Thank you.
My name is Amy Walsh, and I am a family doctor from Raleigh, North Carolina. I opened my own DPC about a year ago, and I do have one disclaimer, and that is that I love direct primary care. I love it. So I also will let you know that I am much more comfortable sitting out there than standing up here. So this brings me out of my comfort zone. But let me tell you how I got here. My previous work life, I was a part-time employed physician at a big practice in a big hospital network. I was tired, rushed, frazzled, looking for codes that I didn't even know what they meant, clicking meaningless use data points that made no sense. I felt like I was part of the hamster wheel. It felt like every day that went by I was doing cookbook medicine, and instead of a family physician, I was becoming a primary care data entry clerk. And so I quit. And the conversation went like this. Thank you. But the conversation went like this. You can't quit. I think I just did. What are you going to do? Not this. And so it wasn't until after I quit that I learned about direct primary care. And it was this whole world that I didn't even know existed. And it felt like DPC was turning family practice upside down for all the right reasons. And it sucked me in. And the more I read, the more I learned, the more it called me to sort of say, this is how medicine should be. And so my first question was, who the hell is doing this? And where are they? And so the more I read, I learned about practices like Atlas MD out in Kansas. I talked to Jeff Gold up in Massachusetts. The Isbickies are in Pennsylvania. And all these great doctors across the country that were willing to help and teach and show me the direct care way. The most inspirational thing for me is when I saw women like Julie Gunther and Jen Harder. I pulled up their websites and boom, there were these women opening their own direct care practices all by themselves. And I thought, oh my God, if they can do it, guess what, so can I. And so on I went, and I did more homework. And it wasn't just the legalities and the finances that I had to learn. Hell, I had never owned a practice in my life, never ran a practice. So it was all that stuff, but all this whole other bunch of marketing, networking, all this stuff that I had to learn. I think I was the only middle-aged mommy in America that was not on social media. And so Facebook was this huge unknown entity to me that felt like a necessary evil, but my teenage kids taught me how to do it. And I learned about personal pages and business pages and boosting and liking and sharing and all this crazy stuff. But I also learned the importance of a well-written press release, and I learned the importance of how to negotiate for cash prices, and that starts with simply asking for them. And that was even foreign as well. I did more homework, and I did more networking. I joined the Chamber of Commerce, and I went to every event that I could where people would be interested in healthcare. And I found that what they wanted to do was tell me their story. Can you believe I paid $3,000 for my urgent care visit and blah, blah, blah? And I said, you know what? I'm opening a practice that's not going to work that way. And so every opportunity that I could take to network and explain direct primary care, I did. It's amazing who you meet. I was fortunate enough to sit next to a healthcare writer who believed in DPC and has helped me further my vision, so that was pretty cool. So I networked like crazy. I hit the pavement and I worked, and this is before my doors even opened. A year to the day from when I finished employed physician practice, I opened Dr. Direct. And it has been the most overwhelmingly exciting year of my career, but more importantly, the most rewarding. I get to do medicine the way medicine was supposed to be done. It's done right. I love it. So not only did it change my tune about practicing medicine or my attitude, but like it changed my whole outlook. Bo Schembechler, the great Bo Schembechler, says if you're going to win this thing, you're going to work it like a team. The team, the team, the team. And that's the attitude I take in DPC. It's a team effort between nurse, doctor, patient to get them the best health care that they can possibly get. But on a larger scale, the team of direct primary care docs across the country support, encourage, share ideas, and spread the word, just like we're doing here. It has been a phenomenal experience from my own take. So I'm going to leave it right where I started off. I love DPC.
Hi, I'm Mike Champy. and I think we're going to have some slides up here pretty soon. But just to give us a jump-off point, just to really give people a brief look into my exodus, it really reminds me of an axiom that one of my mentors in residency used to say. He said, good judgment comes from experience, and experience comes from bad judgment. So I'm going to use my transition as an example of how not to do it. But again, we're in a good place now, but it wasn't always that way. And this is my contact information. And I would ask people, go to my website because it's not the best website in the world, but there are a lot of helpful links. There's a blog there that I contribute to or put up some stuff that might be useful. But the helpful links section I think people might really like, and feel free to steal as much from that as possible because it has helpful links. It has links to the faith-based ministries. It has links to Docs for Patient Care, AAPS, GoodRx. So even folks from around the country that will never be my patients, I encourage them to go to there because they can do some research and find the best deals for themselves. Now, our practice, solo family practice, suburban area in the Northeast, specifically in the greater Portland, Maine area. And if you're in private practice, as you know, you're not going to make a lot of money, so the best way to make any profit is to keep your overhead low. And we have an office attached to our home, which we can get into. There are a lot of pros, there are a lot of cons. For the most part, it works well for us. I have a 50-foot commute to work, but boundaries do get skewed a little bit. We have lean staffing. At the time before we transitioned, we had 2 FTEs, and my wife is a part-time, not including my wife, who's a part-time office manager. Gave up hospital a while ago just because it wasn't cost-effective. Never did nursing homes. Did obstetrics for about 3 months after I got out of the service, but my wife told me that she really wanted me to see our own babies and not just other people's babies at 3 in the morning. So life got better when I stopped doing the hospitals and obstetrics. And our problem was that because we cared so deeply for our patients, we were really providing concierge-level service, but we were being paid Medicare rates, and I'm sure that a lot of people in this room have that problem. We cared too much about our patients, and it was not sustainable, and we were going to go broke. And I had been employed by a hospital primary care practice at one point. I hated it and would never go back, so we had to find another way to do it. The last straws for me were Obamacare, specifically the provision of Obamacare for accountable care organizations, because our local physicians health organization, which did our contracting, let me just take a quick second about that, just as a caveat. There was a physicians health organization that was formed years ago to assist small practices in collective bargaining with the big insurance companies. And somehow, at some point, the big hospital system took that over, so huge conflict of interest. And they kept telling us, we're getting you the best rates, you really have to be a part of what we're doing. And they decided to form an ACO, and they said, in order to get the good rates, you have to join the ACO. And I had a lot of moral problems with that, and also looking into it said, there's not going to be the shared savings will not exist. Even if it does, the hospital's going to take all of it, and I can't be at risk for taking care of sick patients because my practice is barely afloat now. I can't pay to take care of sick people. So I told them that was not going to work. Also, I didn't want to do the paperwork to be a patient-centered medical home, even though really we are all patient-centered medical homes, but just the checklist of things to do to become a patient, even level 1, the checklist is 45 pages long. We didn't have hundreds of hours to devote to that. We had a horrible EMR, was making our life miserable. But basically, they said, you have no choice. You have to do this. Well, I told them we did have a choice. I immediately resigned from the local Physicians Health Organization. And I will say, you know, kind of dovetailing with what Phil said, know your contracts. I was shocked to find out because we wanted to see what our contract said. And the PHO said, you can't have the contracts you're bound by. They said, if you want to look at them, you can come to our office and you can look at the contracts, but you can't take a picture of them, you can't photocopy them, you can't let them leave this building. And my response was, why in the hell did I sign these in the first place if I couldn't even know what I was bound by? So, and later found out that they weren't even giving us really good deals anyway. So that was one of the best things we did, was get out of that arrangement. We opted out of Medicare effective April 1st, 2013, canceled all our insurance contracts. And what we did was, I didn't know about DPC at the time, so I started a cash fee-for-service practice, and taking a page out of Keith Smith's book, we put our prices online for physicals, office visits, EKGs, et cetera. And again, we did that. We junked our EMR immediately, which was one of the happiest things we ever did. Set up a do-it-yourself website on GoDaddy for about $100. Did some advertising on talk radio, and I hope we probably in the question and answer we'll talk about the best way to get your practice going. Paying for print, TV, and radio advertising is probably not the way to go. But I did get a lot of free publicity. When a newspaper article went viral, got put in on the Drudge Report, Huffington Post, The Blaze, and basically it crashed our website because we had so many people looking at it, which was really cool. The best publicity is free publicity. The pitfalls of cash fee-for-service practice, which is why I do not recommend it. It attracted many drop-in patients and drug seekers, thinking, hey, here's some fresh meat, even though I was established in the community for 15 years. Because again, they think, hey, if you're paying cash, I can get my drugs. And if I was not busy, I'd kind of let them talk and give me their sob story because it was entertaining before I tell them, you're not going to get drugs, so, and they just would like run away. It was good. Many patients who stayed tried not to come in at appropriate intervals. They'd be really kind of cagey about it, say, well, you know, yeah, I'll come in, I'll make my appointment, but can you give me a refill for another 6 months? And I promise I'll make my appointment by then. There were not many benchmarks for cash fee-for-service primary care, so we kind of had to make it up as we went along. Income becomes very unpredictable. You are waiting for patients to get sick in order to make money, and that's a paradigm we want to get away from. Patients became way too focused on getting reimbursement from the insurance company. They wanted all the codes. And even though we were not submitting bills, we might as well have been because they wanted everything documented and coded so they could go to their insurance company. Most of the time, they didn't get reimbursed anyway. And we just came to the point where we found that it was unsustainable. So I was at a conference 2 or 3 years ago, or probably like 3.5 years ago, and I was talking about my model, and there was this kind of weird, crazy guy from Kansas named Josh that fortunately his talk followed mine because if he spoke ahead of me, no one would have listened to it. But we started talking, and I learned about direct primary care and realized that's what I wanted to transition my practice to. And we started a DPC option, but left the cash fee for service there. We did, and I do my model a little bit differently. Most people do it as an age-based, but it seemed like I chose, the nice thing about DPC is you can do whatever you want, you know, within limits. We said $50 for an individual, $95 for a couple, $140 for a family per month. Discount for prepaying for the year in advance. If they pay for 11 months, they get the 12th for free. Veterans receive a 10% discount because the VA is not taking care of these folks, and we want to try to do that. Labs, generic medications, and vaccines provided at cost. We are fortunate because in our state, whether the patients are insured or not, they provide pediatric vaccinations. So we participate with that program so we can give our pediatric patients vaccines at no cost to them. We're all paying for it with our tax dollars, but I think that's a public health measure that I think is a really good thing. Our visits are 30 to 60 minutes. House calls, I do house calls, but there is an extra fee attached to that. Where we are now, 300 patients and growing. That doesn't count the cash fee for service that we are aggressively phasing out. We didn't, and here's why I say that, you know, good judgment comes from experience. A lot of our patients were loyal and stayed with us despite the fact that they were having to reach into their pocket and pay cash. It was going to be hard to say, you know, less than a year later, okay, you stay with us once, we're going to make another transition, because I think at that point they would have been frustrated and just left. So we've done a really slow transition intentionally, but since we've been doing this for 3 years, we're going to really lobby hard for people to say, okay, we're going to commit to the DPC option now. Our income now is steady. We are now at the point where we're recruiting self-insured businesses, because as you know, Jay Kempton had talked about, you know, they will see the value because they're paying, you know, the real cost of healthcare for their employees. Personal and professional satisfaction has really gone through the roof. And remember, the transition's hard. Just remember, if you're going through hell, keep going. I guarantee you there are times when you don't see any patients that day, and you don't have as many patients signed up, you're not meeting your goals. Sometimes there is some despair, but just keep going, it gets better. You know, and another bit of advice I'd give to folks is, again, we are all hard workers. We all want to do a good job, and this can become an obsession. Don't let it. You know, put the work in, do your homework, but take care of yourself, take care of your family, because I learned from personal experience, even though my wife is my office manager and she is very vested in our success, she does not want to hear about the practice 24/7. So if I can give you any advice, don't obsess about it. It will be fine, but take time with your family and everything will be great. So, great. Thank you.
Just really quick, I'll just reintroduce myself. I know the Q&A is the most important section. My name is Dr. Chad Savage, and beyond being a connoisseur and very proficient in high fashion, I started Your Choice Direct Care about a year ago. And I'd just like to say in a very quick question, oh, you don't have to rerun my slideshow, that's yesterday's. You know, there's a lot of discomfort in this room. We wouldn't be here if we didn't recognize something was really wrong. And this is going to sound very, very bizarre, but that is a very, very good thing, because innovation comes from discomfort. If we all were comfortable and happy, nothing would change. So the fact that we're actually a little unhappy with the system in a weird way is good, because it gives us the motivation for change, and hopefully some of you, a lot of great innovators up here on the stage this weekend, but the next great innovation may come from somebody who is in the audience today. So thank you.
All right, again, so this panel really is mostly about the Q&A, so if people have questions, go ahead and start lining up by the microphones. Just want to say a couple words here. It's incredible the success of these people despite their handicap of being Michigan graduates. And so now we need a couple Ohio State folks to replace these two up here. Go ahead and start over here.
I had a question about office space. When you start up, what does the panel think about the minimum office space needed?
The least you can afford to get away with. When I designed my office, it was designed for 3 docs with 9 office or exam rooms. I now have 2 docs and we operate out of 3, so basically each of us are working out of 1.5 exam rooms. I cannot stress this enough. You've got to keep your overhead as low as possible in those early months to try to give yourself a little financial cushion so you can make it through the initial stage, which will be lean. I mean, I don't know that there's any way of getting around that. Actually, an extrapolation of that question too. When I first started, I came from a insurance-based practice. We had massive overhead, tons of staff. When I talked to Josh, and everybody keeps referring to him because that crazy hermit helped us a lot of us start this. He's not even here to hear this. Here to hear the insults. Anyway.
So, yeah, we can say whatever we want about it.
Yeah, he can't retaliate. How wonderful. I was telling him we were trying to determine the right ancillary staff to physician ratio, and I was saying, well, maybe I'll cut it down to 2 to 1. That'll be great. And he goes, no, you're crazy. It's 3 to 1. I said, really? 3 staff? He goes, no, 3 docs to 1 staff member. And I thought, oh my God, that's crazy. And I will admit, I did not go that far, but I am 1 to 1. Actually, we're 2 docs to 1.5 staff. And that's fine. The whole concept of this model is you're cutting away all the fat and you're making a direct line between the patient and the doctor. So you don't need to have a boatload of essentially walls between you and the staff. But keep that overhead low any way you can. We can't tell you the exact space because only you know what that's going to be. But think outside the box. Keep it as small, as tight as you possibly can. There's even one doc who doesn't use a practice. He actually just purely does DPC on the road. His overhead's insanely low.
1 exam room is all you need because you're only going to be seeing 1 patient at a time. I was shocked when I visited Josh's office, and I'm like, you got 3 docs here and 3 exam rooms. He goes, we only see 1 at a time. Our practice is about 1,700 square feet total, 2 of us, each with 1 exam room.
Yeah, and I've got, again, it's attached to my house. It's 1,000 square feet, which is plenty. We could do it probably we could do it in almost half of that if we wanted to. We have 2 exam rooms, which is kind of nice if someone's getting nebulizer and I want to sneak another patient in, that's great. But it's nice, but it's not necessary. I could easily do it out of 1.
Bill, do you want to comment on owning your own space and whether that's good or bad thing?
I do. I think I'm a plant for telling people how not to do things. A year before Lee and I launched, we purchased our own medical office building. It's a 6,000 square foot space. We do have the ability to lease to other professionals, which at times we've been successful in doing, and of course that seems like a great business model when you have it leased out. There are times when it's not leased out, and that's again, adding to the overhead. So I think the concept of the micro practice is certainly where you want to be, especially if you're starting out and flipping the switch. But again, out of necessity, we had to do the hybrid because our overhead was too great to switch. So these are important considerations, so that's a very appropriate question.
Thank you.
I was wondering if, and I'm going to record you because I want these, but I was wondering if you would each give us your 30-second spiel to the patient that's in your practice or that you run into, and you got 30 seconds to tell them about DPC.
Who wants to start?
I'll start off with the patients all know that their insurance suck. They get that. I mean, trust me, they get that. You think you're poking them, they know their insurance sucks. They don't like it either. It doesn't work for you, it doesn't work for them. So that's a very easy starting point.
Can I ask a clear?
No, you're telling them though, Lee. All right, you just ran into me. I'm your patient. What are you going to tell me?
So I'm going to leave it to the
Okay.
panel because you've heard enough from me.
You're asking a clarifying question, right? In the sense of you're in insurance-based practice, you're making the conversion. How do you tell that person? Is that what you're saying?
Not how do you tell them, but talk me into joining you.
How do we sell it?
Sell me.
Your elevator pitch.
Yeah, your elevator pitch.
Well, I guess it depends a little bit on that. Know that person, first of all. Before you see them, know a little bit about their situation. Try to maybe peruse a little bit. Before you get into your 30-second go, does that person have a high deductible? Maybe go, hey, I'm just curious, what kind of insurance do you have? Oh, man, I got this terrible high deductible thing. Oh, good. I want to let you know I'm making this conversion to help someone like you. Remember, they don't really care that we hate the system. It's all going to come back to why this is good for them. So you may have to custom tailor that a little bit. I don't know that there's one, this is my hit the button and go. I mean, I know I mentioned the 1-minute presentation yesterday, and that's kind of for people you're seeing in the community and such. But in reality, I don't know that's a very easily answerable question because you have to tailor it and read them. If you can do that face-to-face, that's so much better because you can see if they're glazing over or not, and then you can migrate to the areas that actually do interest them.
Here's what I say.
Thank you.
So at our office, we do things differently. We don't participate with any insurance, and instead, we offer a monthly membership. For that monthly membership fee, which is less than your cell phone bill or your cable bill, you get essentially all the primary care office visits that you need. We couple that with discounted labs. For example, a cholesterol panel is $5.50. Medications that are as close to wholesale cost as I can get them to you, and you have access to me, meaning you get my text and my email.
Thank you.
And another thing, so another thing that, that resonates is, when we take money from your insurance company, we have to play by their rules. We have to do exactly what they say, how they say it. They determine what you get, when you get it. When we don't take the money, we make our own rules. So we're at a time in medicine where we can customize your care down to your own DNA. We can do a blood test to determine what's the best drug to use for you, yet your insurance company is telling us we have to take a one-size-fits-all approach to patient care. So we are going in the opposite direction of that.
Right, and I tell people, you're contracting with me, so I'm responsible to you, you're responsible to me, there's no middleman interfering. And sometimes if I think of it, I have this meme, the stick figure, it's like, this is Bill. I made one up that said, Bill, this is Bill. Bill has crappy insurance. Bill gets great care from a DPC doc. Bill is smart, be like Bill.
Over here.
Hi, I have two questions. One, if you opt out of Medicare, can you still teach residents and students in your office? And the other one would be if you have any suggestions about a flow sheet of how to create a budget, what things to put in your flow sheet to, as a startup, what things do I have to include in that flow sheet?
Well, I don't see why you couldn't teach medical students. I mean, you're not billing for their services, so I don't know why you couldn't teach medical students and residents.
If they're billing for your services, you got to be careful. That's a great question for Phil if he's still around. I would prefer not to.
I think when you staff in a clinic, which I do right now, they have to let Medicare know because the residents bill under your name.
Oh, but if you're not,
if you're staffing in a clinic, but I don't know if you're in your clinic and they come see patients with you.
yeah, you're not billing.
Then
You're not billing
billing
Medicare.
them.
Yeah, so we have no lawyers on this panel, so we don't want to give you legal advice, but
Yeah.
I would use caution at trying to opt out in one place and being billed in Medicare in another place, unless it's an urgent care and emergency room situation where there are some clear carve-outs for that.
Right.
But if you want to address the costs in the flow sheet,
Yeah, in terms of flow sheet, it is good to develop a spreadsheet. If you have an established practice now, take a look at your budget and see what you want to keep and what you don't. You can definitely decrease your staff, which can be an interesting conversation. I find that I have one full-time MA who does phlebotomy and answers phones, and she's fantastic. And my wife is my office manager, who is my boss. So again, you reduce your staff, but you have to look at malpractice, business insurance. You want to have some liability, your own disability insurance, and so forth. Rent. Look at what you want to do for rent. But if you're going to start a new practice, again, maybe you can lease space from someone else. Some people do that initially, just rent a couple rooms. So you take a look at what you're doing now, what you can get rid of, what you can't. The first thing we did was got rid of our EMR, and we actually went back to paper, which I know that's kind of unusual, but I can talk about that with folks later if they want to. And we use Hint. They're not paying me to say this, but it makes the management a lot easier, and they charge 1%, which is reasonable for all the hassle they save us. But when you're setting your rates, you try to work backwards. Say, how much money do I need to stay open? How much money do I need for my costs? How much money do I want to make? And you try to work backwards from there in terms of determining your pricing. But that's, don't really want to get too into it. But I can just say for my pricing, I put it up there. My goal is 600 patients. And if each patient is paying me $50 a month, that's $600 per patient times 600 patients. That's $360,000 gross. And most practice, our costs are about $100,000 to $120,000. So if you do the math, that's a family physician making over $200,000 a year.
And doing what they love.
And enjoying what they're doing. So, right. So that's a pretty good deal.
Yeah. If I can just quickly add to that. So I did what's called zero balance budgeting. I was an employed doctor. I had access to my financials. So I went through it line by line, and every line that said administrative costs from the hospital I crossed out. That was a lot of money. So immediately I knew I could cut my costs. And I said, okay, this is how much it costs to run my practice in total. Now I'm going to divide it by the number of patients, subtract out what I expect for a salary, and there you go. And in fact, you could continue to reduce those costs as you cut all the, again, you may love some of your staff, but you're going to very likely have to let some of them go to downsize into a model that works with DPC. Not only should you do a budget, but you need to do a timeline too. Think about this as far ahead as you can. I had some people, wonderful people from Michigan I was just talking to a little bit ago, who are about a year out from a conversion. And this is wonderful that they're thinking about it now, because they should actually sit down together as a group and figure out a timeline for this conversion. And make this deadline, I want to have this done and this. So when you do roll it out, it's as finished a product as you can have. You don't want to look like you put this together with bubble gum and some duct tape. You want it to look like a good finished product so people could, this is an uncomfortable concept for a lot of people. You want to have as finished a product as possible so they can have as much comfort in doing this as possible, and you want to knock out every reason they can tell you no, whether that be the financials, we got the meds, we got the labs, we got everything else, whether that be your professionalism, accessibility, whatever it is, you want to have every question that they could come up with handled. So educate yourself now. The group, again, from you're out, educate yourself, educate yourself, educate yourself. When the questions come up, know the answers.
Okay, so I have a meeting in a few weeks with the president of the American Medical Association. Did you know that Andy Gurman does not use an electronic medical record?
But his life's a lot easier.
Yeah. Over here.
I'm looking at converting a full traditional practice within the next year, and if I were to do a hybrid model for at least a short period of time, how do you schedule your day? I mean, if I'm full, 22 patients a day, how do you fit in those membership patients in between all of that and still give them the care that you've promised them? And then just another quick question, how do you verify that you're not charging someone who is Medicare eligible? What things do you have in place at the front desk to make sure of that?
Well, that's a good question. We identify the Epiphany patients, the direct care patients. They have a different colored chart than the other traditionally insured patients or Medicare patients. So we just have different chart colors for our Epiphany patients, our direct care patients, and that helps identify who they are. We also have access to our schedule where we have a certain block time for acute visits. Really, we don't treat patients differently, so they always are going to get in the day they call. We've been doing that for a long time, even before we started this program. So everybody gets in basically the day they call. So we have set aside time, and we have also set aside time for new direct care patients, because those are going to be longer visits, 30, 45 minutes, even an hour at times. So you will win through your scheduling, and you have to own your schedule. But I think that's going to be the biggest tip I have for you.
Yeah, great points. And, our EMR flags us when the patient is a DPC patient. We don't, the challenge we had is we always treated our patients like they were concierge level care. We always had extended visits. We always had see your doctor the day you call. We always had, you never see the other person's patient. We always had same day appointments. We always had these visits. So this was not a challenge. We don't treat people differently because they're DPC. We treat everybody the same. So it's just active schedule management, quite frankly.
I'm an all or none kind of girl, and I wanted it simple. So I went all DPC, and that was it.
Right.
It can be a hard choice between the two as well. I mean, Lee and I have known each other for a long time ago, and I knew what he was doing. And what I actually really considered the hybrid model before deciding just to go into DPC. And I think the analogy is kind of the Band-Aid analogy. Do you pull it off quick, or do you do it slowly? I think there's a huge attractiveness when you're thinking about the hybrid, mainly if you have an established practice and you have a lot of personal costs. You have a mortgage designed around an expectation of a certain level of income. That is hard to account for that, because you may be stuck in a 30-year mortgage, and you can't alter that easily. There's only so many things we can change. So I think Ryan, though, made a good, because my thought was, okay, great, hybrids can be the great stepping point into full DPC, because really what's the concept of the hybrid? And most people are doing the hybrid with the thought, eventually I'm going to step into full DPC. But Ryan, actually, earlier, he and I were talking about this, and he said, yeah, but how many hybrids have you seen that have eventually converted to full DPC? And I don't know if you guys know of any that actually have.
No, I don't. I mean, we're still, we've terminated our contracts with United, with Aetna, with Humana, and with Signum. So we're basically Medicare 65 and over, DPC under. If I were coming out of a situation where I had no patients, no practice, no fixed overhead, I would not start a hybrid. That's like asking somebody to start heroin with the intention of quitting it later. It makes no sense. But if you own your space, you've got a mortgage, you've got fixed things. We don't have moonlighting, a lot of moonlighting opportunities where we are. And so you have to consider that. You have to consider, if you opt out, what does that do to your moonlighting opportunities as well? But yeah, I mean, the DPC micropractice is a far superior animal. The question is, can everybody do that? And the answer is, quite frankly, no. But most people should strive for what these folks are doing.
Just a quick comment on that too. This is purely hypothetical because I'm not doing a hybrid, but my thought would be is that you maybe set up a timeline for yourself. You go, I'm doing hybrid, I'm doing it for 3, 5 years, whatever it may be, with the intention. So you kind of keep a little bit of pressure on yourself and you start moving to that final goal.
And I've seen some people do it either way. Some people will say, Medicare is my worst payer, they're gone first, or they say, well, if I get rid of Medicare, I can't be a hospitalist as a moonlighting. Some people will say, okay, every month or two I'm going to get rid of my worst payer, my worst commercial payer, and work it down. The nice thing is you can really structure it to the way that meets your practice. That's the beauty of DPC.
Okay, over here.
2 quick questions. Chad, you mentioned that you started this model a year ago. Mm-hmm. Would you mind me asking how large your panel is for DPC?
I'm in the mid 500s,
Okay.
and I hit my goal. My goal at the end of the first year was to be at 500. I will tell you, I had false expectations when I came in. I'd heard people talk about these very small panel sizes, and I thought, I have 3,500 patients, that's crazy. I said, a bunch of lazy guys, you're so lazy. Again, he's not here. Because he was actually laughing at me, and to his knowledge, he kind of went along with my ignorance on this. And I was like, Josh, I'm going to do 1,000, okay? You can keep at 600, I'm doing 1,000. And I came up with that number because I went by historical norms. Prior to 1980, the average doctor had on their patient census about 1,000 patients. I thought, oh, great, go back to historic norms. This is the aberration, 3,000 patient panels is the aberration historically. So I thought I'd go to that. But what I didn't realize is we're not actually just going back to the way it used to be. We're doing something far more. We're doing, we're doing higher levels of care than even probably they did back in the 70s, and we're adding in pharmacy and other services. So now I think he was right. Don't tell him I said that. So now I'm thinking I'm probably still a little more robust. I'm probably going to go to 700. But I mean, I'm 150 away from that a year in, and I don't think if I had started up an insurance-based practice, I would have come anywhere near capping out within a year and a half.
What advice would you give to someone about determining whether for example, for me, how do I determine whether I have the demographics for a direct pay model? There's got to be a way to figure that out.
I think that I would not spend money on surveys and things, extensive. You may do maybe an informal survey in your office and say, hey, I'm considering a new model. What do you think? That actually may be helpful. It may give you a little feedback, and even if people are willing to put their names on it, give you a kind of an idea as to who to go after. Amy's got something to contribute to this too.
Josh has a little survey that you can throw to your patients, say, hey, would you like to do this? Would you like to do this? And it almost, it feeds right into the direct care model. When the patients all say yes, you're like, this is what I'm doing.
But remember, I think there's also a bit of a fallacy there. How do you make sure the demographics fit? That kind of implies an assumption that you have to be wealthy to afford DPC. If you structure it well, my biggest area of growth is actually the working poor. And in fact, non-insurance, Medicaid, yeah, sure, I got rich people who see me too, and I will not bilk them just because they're rich. That's great. That's the difference between us and concierge. But actually, the Think Freely Media did a video on us that should be coming out soon, and they have a wonderful story about someone who hadn't accessed care in many years. And we finally brought the cost points down. She had so much pent-up demand. We actually are a saving grace to a lot of these people.
Right, and that's the thing. Who stays and who doesn't is so unpredictable. Every DPC doc I've talked to has the same story. Millionaires will leave your practice who could afford it very easily, and people on Medicaid will often stay because they value the services and the time you give them. So totally unpredictable. It is emotional.
Yeah.
You will toughen up, but it is really emotional. People that you've saved their lives several times will say, "Oh, thanks, I'll see ya." And people who you didn't think they even barely knew your name, they'll stay with you because they love you.
So no one's going to tell you the transition's easy. From the day you announce it, and I would encourage you to give some warning to your patients, but not so much that you're empty for like the last year of your insurance-based practice, but give them at least 3 months warning. During that transition, when you meet with them individually, schedule a little extra time to tell them what you're doing so you can have those one-on-ones. You'll retain more of them that way. But understand some people will accuse you of selfishness and other things, even though you're actually likely going to take a transient paid drop to do this. And then in the first several months too, you're gonna feel forlorn. A lot of those people you thought were going to sign up don't. But then you get to the stage where many of us are now, and the people love you. They recognize what you're doing. So you're going to have a little bit of a dip before you have the ascent, but it's worth it.
I think that all the demographics fit this. Patients love it. It is just hard to get them to think about their health care differently, just like it's hard to get doctors to think that there's other models besides traditional medicine.
One more point about our transition, as we've eliminated insurers, a lot of people choose not to convert to our direct care component, and they leave the practice. And it is amazing who chooses to stay and who chooses to leave. But what we're seeing now is they've gone out, they've tested the waters, they've been to the competition, and they're trickling back, and they will come back. So, you're going to get a lot of records requests. They're going to want their records signed out, they're going to go down the street, but they will come back.
Right, and by the way, this is just a plug for Doug Farrago's book. He lays a lot of this stuff out, and actually I think in the appendix, Kim Korba contributed to the book, and she has some scripts that you can use when talking to patients. So in a disclaimer, Doug, I was one of the people that kind of proofread the book for Doug. He gave me a free one, but other than that, he hasn't given me a damn thing. Cheap bastard.
Thank you. Over here at this microphone.
So I'm going to transition, like within a month, to a DPC, and I've got a full practice, fee-for-service. I'm also a pulmonologist, and so I do get consults. How do you suggest I charge for those pulmonary-only patients? Any thoughts?
Are you opting out totally of insurance then?
You know what I'm going to do? I'm going to do it gradually, 1 month at a time, like United first, and the second worst, third worst, fourth worst.
Probably the hardest thing there would be also talking to your referring physicians on that one and kind of making them aware. I know when I converted, actually, I thought about my patients immediately, about getting them aware. What I didn't realize is I have to educate my peers, because I had specialists I was referring to for many years who went, "Oh, that's crazy crap. You don't need that concierge BS." And I'm like, oh, God, they don't know what I'm doing, and they're insulting me, and they're driving patients away. So there's several layers of education, and yours would be the reverse. You probably need to educate your referring doctors as well.
Right. So with that, if for the specialty care piece, again, it might make sense to do that fee for service, especially if you're cutting your overhead. So, I mean, when I went cash fee for service, primarily, I cut my rates in half, because that was a weird thing, because the insurance companies tell patients, hey, he's out of network, he's going to bilk you, because he's not bound by our contracts, he's going to be a greedy doctor and bill you 3 times what he would have gotten otherwise. The opposite was true. I cut him in half. So again, without the admin, you can cut your rates in half, and you will get the attention of people, because with these bronze plans and so forth, people are paying cash for their health care. So if you would probably, once word gets out that you can get a pulmonary consult for whatever, say now it's being charged at like $400. If you're willing to take $200, word will get around, and that will help to grow your DPC internal medicine practice as well.
Right, a lot of those people stick with me.
Exactly. They say,
think-
wow, I can get all this care for a reasonable price.
I think one thing we're often guilty of is undervaluing our services, and I would just caution you, do not undervalue your pulmonary services, and just be very transparent in the price.
Over here.
Kirby Farnsworth, just as a quick update, I'm a graduated residency in June, we just opened our practice 3 weeks ago. We've only got about 60 patients so far, but I don't know any different because I'm living on a resident salary, so it works out well. Our official micro practice kind of numbers, we started a 3 exam room office for about $25,000 out the door. And then we've got another 6 months budgeted out for expansion, so it can be done very, very easily. My question to you, and the models that I've seen, there aren't very many kind of dual practitioners, or seems like most of this model really fits a solo model. How do you coordinate scheduling with your patients as far as I'm going to leave the town? Do you employ people to cover your shifts? Do you have locums people that are covering? Or is it just an understanding with your patients that I'm going to be out, you're going to have to go to an urgent care or an ER if I'm not available?
There are other DPC docs in the area that we just cover for each other. Just kind of like the old-fashioned, hey, I'll cover you, you cover me when we're on vacation, no money changes hands. And and actually the amount of patients you really need to see is pretty low, because as you get more experience, there's not a whole lot you can't handle over the phone. And I'm taking call for myself, from Dallas, and between what's an emergency that needs to go to the emergency room and you have stuff you can handle over the phone, stuff that has to go to the ER. The window in between is actually very small. So it's not a problem, and usually you have someone cover. Again, we just do it for each other.
Yeah, and we actually have a 2-doc practice, so my partner's covering for me so right now. But in that first year, I didn't have a partner. She joined me just recently, and she's wonderful. But there was a doc one town over that we had kind of a quid pro quo that, if he took a week, I would cover him, and if I took in, what happened? None of us took a vacation that first year. But it was there. It was an availability. And honestly, again, the volumes are much less, thinking like the insurance model where you just a massive demand for your time. It's much less. You can handle so much through telemedicine and such. And maybe until you build a lot, you don't go for 2 weeks to Hawaii. I hate to say it.
Over here.
I have 2 questions. The first one is I've always been an employed physician in a rural setting, and I think I can open my own practice, but it would definitely be in a rural setting. So I have a question about getting x-rays, CTs, ultrasounds for my patients, and especially in a system that maybe I just left and they don't want to do my services. So I'm wondering how you work that out. And the second question I have is I'm wondering, I've done some pretty onerous call situations, and I'm just wondering, since you give your patients so much access to you, do you find that they're respectful of maybe the 3 a.m. time when you're dealing with your own kids and you don't want to be dealing with theirs?
They're very respectful. One, because we answer all their questions and go through all the information and scenarios when they're in the office. So in a year of having a DPC practice, I've been called after 11 p.m., I think, once or twice, maybe. It just doesn't happen.
People know they're calling you personally. So they tend to be, if you're in a big group, they have this false expectation that you're sitting at a phone bank just twiddling your thumbs, excitedly waiting for that call. They have no idea that you're at home sleeping, and I always used to, maybe I shouldn't have done it, I used to be, oh, hello, even if I wasn't that bad, just to make them realize what they were doing. But in this situation, they know it. And in fact, I get people who are so apologetic. Oh, I'm so sorry. And I'm like, listen, you've never called me before. I know it's a true need. So it's actually, you find it's actually very rare.
Yeah, if I get 2 calls on a weekend, that's busy, and I'll go for weeks and weeks without a call after hours during the week. So they are. People are very respectful because they know that they're going to answer to you the next time they come in.
Regarding your first question about the imaging, even though the current employer might be competition in the future, they will still welcome that business. So they will not turn away your patient. I think they would just welcome the business for the imaging services.
I guess I have one question for you guys. I have not personally had any success at negotiating with a hospital for anything. And in rural settings where oftentimes the hospital is your only option for imaging, have any of you had any interactions in trying to deal with that?
Yeah, it's very market. It's really dependent on what the market is, and yes, sometimes that's not. It's tough, and some hospitals might give you a 25% discount if you really beg for it. But the trouble is their markup is a couple $1,000%, so they're happy to give 25. So if there's anyone that has, say, like for X-ray services, ultrasounds, if there's an orthopedic practice, a private orthopedic practice, ask them, hey, you've got the X-ray machine anyway. Can you do X-rays for me if someone comes in and gives you $25? Ultrasound, same way. So look at the private practices and talk to them to see what services they might be able to share with you, because if they're paying the overhead for that stuff anyway, $25 here or there or $100 here or there for an ultrasound, they're already paying for it. They might be happy to add that to their income, and then they might actually add more services. So it's market dependent, but think outside the box and approach those people. Chiropractors have X-rays. Plain films are actually harder to get for us than ultrasounds and MRIs.
Yeah, lead-lined walls. That's the issue with that. Yeah, I agree 100%, because we have an urgent care near our house or near my office. It feels like my house. That would do that exact same thing. So one also comment about being rural is, I hate to say it, but people are kind of used to driving when they live rural. So you may be, for urgent situations, you may be a little restricted based on how much availability you have near you. And for maybe something that's a lower cost, urgently needed test, you may not have as many options. But my sister lives on the opposite side of our state. She paid over $1,200 in co-payments for an MRI. She lives very rural. When I told her I could have gotten that same MRI for $300, she drove across the state to access that. So, if somebody even adds in an hour drive, but you're able to find a regional imaging center that is a privately owned imaging center that gives good prices, your just knowledge of that is part of your value, because you're looking for those resources.
That's an excellent point about willing to drive. I mean, we're just a small independent practice in Southwest Florida, but we see patients. I have patients from Miami and Orlando that drive 2.5, 3 hours away. And in fact, we just signed up a patient from the Caribbean, and so she's going to be coming to the Caribbean for her medical care. I'm not doing house calls, but she is going to the Surgery Center of Oklahoma to have her surgery, and we're coordinating her medical pre-op and post-op.
To answer Lee's question about if we have any success with the hospitals, I particularly stayed away from them because they were pissed I quit. And I found that they're part of the problem, not the solution. So I specifically, when I go to negotiate any cash rates, I go to independent practices, independent businesses, and go that route first. They're much more nimble and able to negotiate and more willing to give you a cash fee up front. Hospitals, not so much.
I want to move on to the next question, because we have a few more people, these three here, and those will be the last three questions. Over here.
Two brief questions. One to Lee, because you mentioned something about having a hybrid practice in which all your patients are treated the same, concierge care. What did you tell your patients to have them move over to the DPC side of your practice? And to the panel, I'm in an area where I may not be able to necessarily negotiate a lot of low-cost services. So for my patients with HDHP plans, how do you guys deal with things like prior authorizations for the folks that need that?
Bill, do you want to address this first question? In terms of how do you tell the patients and when you're transitioning?
I think transitioning the patients, when you drop an insurance, it's really going to be their only option. They can either pay cash. Some of them are going to be able to submit a claim to their insurer and get reimbursed if they opt to pay cash. We want them to join the model, but sometimes that takes time. I think that as they get more familiar with the model, this is a new concept. We've been here for 2 days and we still have a lot of questions. I think there's a learning curve not only for us, but also for the patients. So just being available, being familiar, but again, some will leave, some will opt to pay cash, and hopefully they will eventually join the direct care.
I was talking to Phil earlier about individual Blue Cross, Aetna, United contracts and how to get out of them. And he said they're kind of all different. Some have different 60, 90. And I was wondering, like, just individually, what did y'all experience? Because I remember Amos Lee signing things when I was employed, and I really don't know each contract with each insurance, what I have to do to get out. What were y'all's personal experiences with each of them?
The only one that gave me a hard time was United Healthcare. They threatened to sue us. And we gave them a 90-day notice, and they claimed that we had to be 90-day notice from the renewal date. That was from the renewal date of the contract, not 90 days from when we decided we were done with them. And so they really insisted that we stick in there for like another 9 months. It was a crazy period of time. We went round and round about it, and it wasn't pretty, but it didn't end up going anywhere.
Yeah, and we used the physician health organization held all our contracts that they didn't want us to take back, but we were able to get the names and the contact information, so we went through and let everybody know. And there was some trouble because they said they were going to let people know too, and they didn't. There was about a month or two where we had to basically see some of the Anthem patients for free, but it wasn't terrible. It was just the cost of doing business. But yeah, it's doable. You might get some stragglers now and then, like a few months into it. You know, some insurance company that has like one patient will complain, and you say, but usually you can smooth it over and you just give them notice.
If you're employed and you're leaving, the employer should legally remove you from that contract. And so that's either via your HR credentialing department or whichever, and that's what I asked them to do, is take me off everything.
Yeah, the other thing you've got to be careful of, and I know you had a second question we didn't answer. I'm going to get back to that because I don't remember what the question was, and then we'll take that last question here. There are a lot of insurance companies or plans that are underwritten by an insurance plan. So you might have a card that says Golden Rule, but that's United Healthcare. And so if you sent your termination letters out to all your patients that have United Healthcare, and then this patient shows up with Golden Rule, that is technically United Healthcare, and you didn't notify them, you could run into some issues. So those were some other challenges that we got where you dropped a plan, but you didn't notify the patient, so we still kind of had to see them, but we just didn't bill for it, so you didn't get accused of patient abandonment. What was your second question, sir?
Yes, for the patients with HDHP plans, I mean, you may not participate with their insurance, but yet they may need prior authorizations for, procedures or, certain medications. How do you, in your experience, how do you handle that?
It's only been a problem with the HMOs.
I mean, that's part of the service. We say, listen, we don't want to deal with the insurance companies, but because you're our patient, that's a service that we will do, is we will get your prior auths done. But we just do it as a service to the patient.
It depends on the insurer. Unfortunately, if they're a PPO, it's not that big of a deal, generally speaking. The HMOs can create problems. Specifically in our area, it's Blue Care Network. They will not allow us to do a referral unless they pay us, which just seems very bizarre because we're essentially providing a service to them for free. So you wonder, why would they make us receive a payment from them to be able to do a referral? And my conspiracy theorist in me is that that's because they can't have an uncoerced doctor, right? Through the various payment net metrics, they can actually incentivize you to not order MRIs and things of that sort. So they can't have you, crazy independent doctor, ordering stuff independently. Just as a quick diversion, I actually really think that there should be legislation that says you cannot discriminate against the patients about how they get their care, but that's a different issue, and I could go into that. So it depends on the payer, unfortunately.
Well, and that's another topic. HMO patients are not ideal DPC patients because anytime they need a referral, they need it from a network doctor, and you will be out of network. So again, as Lee said, PPO patients are great, even though the insurance companies might try and give them a hassle. They shouldn't. But HMOs can make it tough because they will refuse all your CAT scans, MRIs, and consultation requests.
There are some self-referral HMOs too, so that we don't have any issues with them. And then sometimes your cash pay price is less than their copay, in which case you shrug.
Ding. We offer them cash prices on their meds and their testing before we start doing this prior auth stuff. 9 out of 10 times it's cheaper.
All right, so we're running about 10 minutes long. This is going to be the last question, and then this next panel coming up, we have 10 people that are going to take the stage that are in practices that are going to share some awesome stories of big wins, big losses, and really give you some great stuff. So,
if you're trying to fund your DPC and you're fresh out of residency, to say you're moonlighting or doing hospital medicine, can you simultaneously be accepting Medicare, Medicaid through your hospital practice while, through two separate entities, having your DPC started, have them on a cash-based retainer, only accepting cash from those patients and then still seeing the Medicare patients on the side?
Oh, that's a Phil question.
It's a Phil question. Phil has some great stuff on dpcfrontier.com. There are definitely some exemptions in terms of where you can opt out in one location and moonlight in another, and I want to say that those exemptions are hospice, emergency room, and urgent care. And I don't know if there are others, but Phil would be the one to answer those questions.
Yeah, prison systems. And I don't,
prison systems.
I'm not sure about
but the hospitals have to sign an exemption. They've got to go along with it. They have to know it. They have to know about it, and they have to be willing to play along with it.
And I don't know about the VA and the DOD, if you can moonlight there, but that's a Phil Eskew question.
All right. Thank you, everyone. Thanks to the panelists. Another great one.